Hey everybody, welcome back to the ECG channel. My name is Reed, and don't forget that you can download the PDF down in the description below and follow along. And feel free to like and subscribe to the channel if you enjoy the content. So let's jump into it. So the first thing I'm going to do is kind of look at the forest and figure out what is going on with this ECG. So maybe I come down here to this V5 rhythm strip, and I see I've got a narrow complex rhythm. It seems to be pretty regular, and you see that narrow complex rhythm is regular for the entirety of the strip. It's reassuring. And I do see some nice little P waves in front of my QRSs, right? So this makes me think that probably driven by the atria. But let's look at the rate here. My QRS on a solid line, 300, 150, 100, 75, so maybe like 78 beats per minute, right? Just a little faster than 75. And so in the setting of some P waves with a narrow complex QRS, this makes me think that maybe it's a sinus rhythm, but let's evaluate. So let's evaluate the morphology of that P wave. I see the P wave is upright in lead 1, and I would say it's upright in AVF. That tells me that my P waves are going down and to the left, which is what they usually do if they come from the sinus node. So we've got a sinus rhythm at 78 beats per minute, and let's figure out what the PR interval looks like, really what the AV node, how it's behaving. And so I see that I have a PR interval. If I look here, my PR interval is in between 3 decimal boxes, or 120 to 200 milliseconds, which is normal. And I look and scan through and make sure that all of my P waves have a QRS complex and that there's no extra P waves that don't. So every P wave, it looks like as you scan through, has a QRS. So it tells me that the AV node is working every time it is called upon by the atria to pass signal down. So that's good. Next thing I'm going to do is evaluate that QRS complex. My QRS is narrow, right? We said the duration of my QRS is less than 120 milliseconds. My QRS axis is upright in lead 1, and it's upright in AVF, so it tells me that my QRS is going down and to the left, which is normal. And I see I've got little septal R waves in V1 that are growing. You can see V3 is kind of a little messed up, but you can see the QRS is like right there. So it's growing, and it's nice and tall in V4, so it's good R wave progression. QT interval, right? Pick an R to R interval, midway point, make sure that that T wave is done and terminated by that point, which it is, and so we have a normal QT interval based on the rate, which is what we do here. We can obviously calculate it and correct it for the rate if we would like. Last thing I'm going to do is look for pathological Q waves, which tell me about previous or old myocardial infarctions or any ST or T wave changes, such as like ST elevation or depression. So, you guys probably saw it. We've got, once again, ST elevations that are predominantly in my inferior leads, right? 2, 3, and AVF. What's interesting is you can see it's most dominant ST elevation in lead 3, and then to a lesser degree AVF, and then to a lesser degree lead 2. And if you look at my inferior leads, the way that they project, probably most of the myocardial infarction is more aligned with lead 3, but it's still being captured a little bit by AVF in lead 2, right? But it's mostly lead 3, and then to a lesser degree kind of over here, right? So we've got this inferior infarction that's more of like a right-sided inferior infarct. I look to the opposite leads AVL and lead 1, you see I've got reciprocal ST depression, right? So we've got ST depression in those leads, and we've got ST elevation in my inferior leads. So that's reciprocal changes. And then I look through my precordium, and the only thing I really see here is maybe a little bit of kind of T wave inversion, ST depression, maybe plus or minus posterior involvement. And so we know that normally the right coronary artery 80% of the time supplies the posterior descending artery, and it also is going to supply the inferior wall of the myocardium. And so this person went to the cath lab and they had a RCA occlusion, right? A right coronary artery occlusion. And so let's put this all together. We have a sinus rhythm at a rate of 78 beats per minute. We have ST segment elevation in the inferior leads 2, 3 in AVF with reciprocal ST depression in leads 1 in AVL. Maybe some posterior involvement. And so this is all pointing towards my right coronary artery as the culprit lesion, which was confirmed, and a successful stent was placed in the cath lab. So I hope this video helps you kind of better see all the different types of inferior STEMIs, right? You're probably thinking, well, I feel like we put a lot of inferior STEMIs. Well, they're common. And not all inferior STEMIs are the same. And so this one was a little bit more less diffuse as last week's. And so it's just good to start catching an eye for these, and you'll just start rattling them off. It'll take you 10 seconds to start evaluating these ECGs. So, but having our good systematic approach is important, and in this case, that's what we found. So, hope this helps. If you have any questions, feel free to drop them in the comments, and if not, thanks so much for watching. I hope you enjoyed, and yeah, have a great rest of your day. See you on the next ECG video.